Hi, everyone. Thank you for joining tonight. This is training session number 8, Building a Capacity Among Stakeholders to Address PCOR. As Chris said, our speaker tonight is Carol White. She is a professor at UT Health San Antonio School of Nursing. She recently retired from her full-time position and continues to work part-time on several research projects. Carol developed and directed the Caring for the Caregiver program at UT Health, a program committed to supporting the quality of life of families impacted by dementia. This program has oversight from a Caregiver Advisory Council, and other projects from this program also are conducted with people living with dementia and family caregiver councils. Today, she will help us reinforce the information we reviewed in Module 4. Okay. I'll hand it over to Carol.
Thanks so much, Michelle, and thanks, Chris, for inviting me to be part of this. I think this is part of maybe the last 5 or 6 years of my 40 years as a nurse. I'm always really interested in collaborating with patients and families. I'm what I call a 40-year neuroscience nurse, so looked after people with neurological problems and always was so grateful for their input more into the care in a lot of my work. But as Michelle mentioned, I led a program for family caregivers. And for me, when we started that program, it was really important to hear what do families want in that program. And I think that was the beginning of my journey into really not just seeing people with a condition of their families as research participants, but as participants in actually designing and implementing the research. So I'm going to talk about I'm just going to give a couple of examples, I think, and hopefully I won't talk too long, and then because I'm really looking forward to our discussion. But to a really nice article in the literature, I think that really illustrates well the difference it makes to have people who are the end users of whatever is happening involved from the beginning, and then just talk very briefly about our project. So just by way of an introduction, we've been fortunate to have actually 3 different PCOR projects or funding for PCOR. And the first one is really to understand what matters to people living with dementia and their family caregivers. And that was really my first opportunity working with a patient advisory board or a participant advisory board or with stakeholders. So working with people living with dementia and their family caregivers and other stakeholders in the community who were vested in the care of families impacted by dementia. So through that project, we spent over the 2 years, I think similar to what you're doing through your project in Houston, understanding what matters to people, what questions are important that we research. And short of finding a cure, we really wanted to focus on what are the questions around care, where are the gaps in care, and where do you see that research can make a difference? And then coming from that into an enhancement award for PCOR just as COVID started, where what came from our council was we need to understand the impact of COVID on families who are impacted by dementia. And then Sarah Massoud, who is a young faculty who works with me, received another PCOR award to really expand our work with Latino families impacted or with families impacted by dementia to Latino communities. And that's important given where we are in South Texas, given that Latinos are about 1.5 times more likely to develop dementia, but only are represented at about 8% in the research. Why is that? How is it that we do not make it possible? And I think engagement, as you're doing with your group and as we're doing, is what can improve that process. And making sure that the questions we answer not only have relevance to, for example, the Latino community, but the research also addresses them, because there's been, if you don't study that population, do we know that what we're doing with Caucasians will necessarily translate to Latinos? So I'm excited about the work that we're still continuing to do with PCOR. I want to touch briefly, and I will watch my time because I think this was a really interesting example in the literature, not our research, but research done with people with kidney disease, chronic kidney disease, through to end-stage kidney disease. And why I wanted to bring this up at this point in time where you are in your process was that I think it's really interesting because not only did this group of stakeholders, patients with kidney disease and their family members help to design the research, which ended up getting funded, but then they helped to conduct the research. So this was a project that started in 2015. And so I know Chris passed this out, and so I'm sure that you've had an opportunity to look at it. So I'm not going to spend a lot of time on the details of the article. But what I did was pull the tables because I think they're really illustrative. So in this project, they convened, similar to your group, and I should just mention before I go on, if you have questions, well, I want this to be interactive. This part I'm going to kind of present, but stop me at any time if you have questions as we're moving through this. And as we're moving through this and thinking about the research question and the design, that's kind of the discussion that I would like to have for the bulk of the session tonight, is in your substantive area, talking about the research questions that are important to you and how you might go about studying them based on your previous sessions. So they convened really a national, working with the National Kidney Association group of family members and particularly mostly patients with chronic kidney disease. And this was their first table in the article. I'm just going to talk about it briefly because I think it was those engagement principles that were present within that group that helped them to accomplish all the work that they did. So trust, honesty, and transparency with the group. There was a co-learning. It wasn't just the researchers telling the stakeholders what they needed to know. In fact, everybody in that room was an expert, and they all, coming from different perspectives, co-learned together. Reciprocal relationships where they really did, there was this iterative process where they would suggest something, talk about it, rework it, and then continue until they got to their proposal. And then also respect for each other's. I think they talk a lot about the terminology for family members. Sometimes we talk with research terminology, but I think it was both ways. Respect also with researchers understanding not only the experience and respecting the experience that families brought to the team. So this is really the process. As I mentioned, they convened this group of experts in kidney disease, particularly the patients and families, and then other researchers. But I think the experts are the patients and families. And the first thing they really did was talked about what are the questions that are important to you, and what research needs to be studied. And then based on that, they did some interviews with the group more in depth and had open-ended questions about what research ideas were essential to them and what came up. And I think your population, there's probably very similar things when I think about you talking when I was there, I think it was last year, transitioning from young, from pediatrics to young adult with cardiac disease and sort of that transition. They talked about addressing decision-making, the need to support transitions in care. And in particular for this group, it was thinking about as they go from chronic kidney disease to more end-stage kidney disease. And then thinking about what outcomes matter to patients. And we'll talk about that in a minute. There's things that researchers always want to study, a lot of them biological, but what are the things that matter for patients? So based on that, the researchers drafted some ideas and concepts, and we'll look at those briefly. And it was this iterative process where they'd get patient input, then they'd modify them until they got actually to the design, submitted that to PCOR for an intervention study, were successfully funded, and then involved this same team, not all of them, but each person was invited to be a co-investigator and involved them in the study, which is just finishing up now. This is kind of a messy slide, But I just wanted to look, I liked how they laid this out in terms of where the concept was. And then the PI presented some ideas and questions to the group. The patient and family gave input to those questions. And then based on that, they came up with their final design. And so I thought this was really interesting. The first thing that the PI said was, what do patients need? I think probably thinking about information. What information do they need to make decisions? But then what the patient and family talked about, it was like, we need to think about what is important to that person's quality of life and choice. And so instead of just saying what information do they need, it's what do we need to understand from the patient and family about their quality of life. So really more specificity in understanding what is important to persons with kidney disease, which the researchers would have missed. And then going to another concept in terms of if patients are already on hemodialysis, what help is needed, if any, to get a kidney transplant. And so thinking, okay, everybody that's on hemodialysis knows about kidney transplant because as a clinician, they would know that inside out. But then patients and families said, let's step back here because a lot of people may not even understand the treatment options. And so they were able to really be much more precise in looking at what do people need. It's not that they need to help with the decision at that point. They need to know, let's go back, what are the treatment options? And then who should be giving that information? And they said there's lots of information out there because, again, I think from reading the article, the investigators were thinking, let's design more information, but family said there's information out there, but we need help to digest it and how to understand it, how to pace it. And so then they came up in the intervention with the idea of a kidney transition specialist who could help them with that information. Any questions or just kind of comments that you have when you think about how families and patients were helping with this design?
I think it's really important to remember that not everybody knows the lingo. So I really love that. I think sometimes my husband and I both have congenital heart defects. And so sometimes we'll talk about things and people are like, what does that mean? So I think that's really important.
I know. And I think, thank you. And I think we as health professionals, I'm talking about myself. I make so many assumptions because it's something I do every day, but people may not be aware of even what are the treatment options. How do I understand this information? And then study participants, I found this really interesting. And I saw the last session you had was actually in looking at study participants. And so the PI was thinking about who will we include? Who is our target population? So they were thinking about targeting people that were, 1 to 2 years away from a renal transplant, where their kidney function was quite low. And then the patient and family said, that's way too late in the disease process. We need to target people earlier in the disease. If we're going to help them successfully make that transition, we need to maybe get people who are much earlier. And they ended up changing the criteria to people with a higher kidney function who were at an earlier stage in their disease. And then similarly, where are we going to recruit for our study? And so they talked about neurology practices and dialysis facilities. But again, the patients and families said that's too late. It's hard to be able to change treatment modalities when you're already at that stage. And so that also changed where they were going to recruit. And then I'm not going to go through all of these just for time, but just the specificity again in the intervention and in the study population, targeting low-risk patients as well as high-risk, and then how that information would be given, instead of just bombarding people, talking about the kidney transition specialist, but also talking about peer support and how important it would be to have partner patients with peer support. So again, a much stronger research design that was more likely to make sense to the people they were going to be recruiting in the study. And then I think this slide is so important in terms of the outcomes. Again, you can see a lot of biological outcomes here, blood pressure, how often they utilize the healthcare system, different things like that. Whereas patients said lack of control is really important. We can't control so much. How do we control the loss of this control? And how do we go on? So empowerment. They talked about acceptance, and then grief that we often don't even think about, that families are thinking about with a chronic condition, quality of life. So you can see they then were, added outcomes to that intervention design that matter to persons with the condition and their families. So as I said, they submitted this intervention study that was, I think, much more tuned to what patients and families needed, because they had input every step of the way, and then were successfully funded. And then just in terms of I think it was a group of 8 or 9 that were involved initially, invited anyone who is willing to commit. And because it is a big commitment to be a co-investigator on the team, and a number of them did commit. They talked about what's a fair compensation for patient co-investigators, provided them with human subjects research training, and then set up regular meetings where they, just as other investigators and co-investigators, they were able to give input into the actual implementation now of this research project. And they had one of the patient investigators who served to check in with all of them to ensure that they felt like their involvement was really meaningful to them, and they were also impacting on the implementation of the study. So I thought that was a really nice, and here it just talks about the different activities, but how important that they were co-producing research together. And I like this phrase, doing research with those who use it, which makes it make much more sense. So they were involved in every phase in designing the tools. They had a number of scales to measure some of the different outcomes. They got involved in looking at what would be the best measure for our patient population, people like me. They reviewed the recruitment materials and helped with them. And then they were involved in the dissemination and have been part of presenting at kidney meetings some of the results. And then in that publication that I showed at the first, I looked at the back, and I think at least 3 of these names are people that were from those 8 people with kidney disease or their family member. Sorry, let me just get this to a full screen. We had this stakeholder council that was made up of people living with dementia and their family caregivers. And I just wanted to highlight that we did interviews with the council to better understand engagement with this group. And these are 2 of the family caregivers were part of our publication with that initial council. And this also comes from the publication in terms of what were some of the themes that people talked about, and I tried to match these up to the principles related to patient engagement. And we heard from people about the co-learning benefiting for them, but also seeing value in the work that was done, the partnership, respect, feeling valued and respected. So I think I was going to stop here for a minute and just ask you to comment on some of the principles that you've seen, I think, that are important to extending your work with this council that you've seen over the last, I guess, year and a half, Chris?
That's right, year and a half.
I think definitely trust is a big one. I think getting to know all of the stakeholders and steering committee members, we have to put trust in each other to be able to, one, share our experiences that we've had and know that each person is going to, keep our confidences and also respect our feelings and everything that, we've been through and have to share.
And I believe also understanding is a big part of this, because we all have different experiences that we've all gone through. So I think it's understanding all of us have something different to contribute to this. And it's not judgmental or anything like that, which really makes it feel so nice to know that, you can speak openly to, to contribute to this.
We're all experts in with different perspectives.
I think to have an inclusive research, which includes these subjects as well, I think that's the best way to start any exercise anyways. And that will give you the best overarching view of what you intend to drive out of that research in first place.
I think as a steering committee, I've noticed one of our big focuses has been communication. So trying to always keep that line of communication open, and both from, all sides of the group, just what we're doing, where we're at, why we're doing it, feedback requests and things like that. So just trying to stay open with each other and communicating the whole step of the way.
Thank you so much. I mean, you've talked about inclusivity, you've talked about respect, transparency, communication. I'm excited to be able to move forward to talking about some of the things related to your content area and the questions. I'm just going to share just a quick example of working with our council. And I think, again, those principles were there and that allowed us to move forward. So we had the luxury of being in person for almost a year and a half when COVID struck. And so then we went virtual, and this is one of our council meetings. But I think it was in April at our first council meeting when we were virtual, we couldn't even really move on with business. What families needed to talk about was the impact of COVID for them and tell their stories. And then in sharing their stories, they talked about this is something that really needs to be studied. And at that same time, we saw the notices come out from PCOR about the enhancement awards, and working with our council and refining what it was we were really interested in studying. We were able to apply and successfully complete that project. And I think what was particularly important was that people really wanted to look at the impact of COVID-19 on families with dementia from different perspectives. They wanted to know what is it about COVID-19 and how it's impacted on care. They also wanted to know, what does it mean for the family caregiver? Because they said the person that's living with dementia may have different perspectives than the family caregiver. So that really drove how we looked at this project. Oh, oops. So I just kind of tried to replicate a little bit, in not such a nice way, the table from the article, and just do it briefly. But we initially had said we just do surveys with people, but then our Stakeholder Advisory Council, our SAC, said hearing people's stories is so important to really understand the impact. It might not be captured in surveys. So we ended up doing a multi-method study where we had both surveys and we did focus groups and individual interviews with our stakeholders. And then when we looked at, similar to the Brown study, when we looked at the surveys that we used, we pulled a number of standardized surveys of quality of life, but they said they're not capturing some of the things that we think are relevant to COVID. And that was true because there weren't really any surveys out at that time early in COVID that were really looking at the impact of COVID. So we added a number of questions that looked at their access to healthcare, what it was like for the person living with dementia, and particularly how it impacted on their social relationships. So I think we got a much better understanding from having listened to our families and what they were experiencing. I've been doing qualitative research for quite a few years, and the guide that we developed for this, again, because I think I was interested in so many questions, when we put together our group of patients and families who wanted to help us work on the interview guide, it was like just completely scrapped. And they really suggested so many open-ended questions rather than sort of the questions I was trying to get up, because there was so much I needed to know, I felt. And I think the revisions they made to it made it such a better conversation guide through our interviews and through our focus groups. And then they changed a number of the wording. We had something about advanced care planning because there was a lot related to COVID-19 and how it was making people think about advanced care planning. And they changed the wording because they said we use that word all the time, just as we talked about terminology. Many people may not know what that means. So we were able to make the guide more specific to our population. And then we also, again, had a couple of workshops, one around principles around ethical conduct of research, because some of our council members were helping us with the data collection. And we always had a council member participating on the interviews or the focus groups with us. And then they also needed to complete a course in ethics, the practice-based research course that they completed. And then, as I said, they participated in the focus groups. We had 2 caregivers who helped us analyze the data with our team, and then were able to participate in the publications. And these were the different publications. And you can see they really, this was with the person living with dementia. This was a quote from one of the people talking about being on Zoom. And I liked how he called it an animated socialization without its substance and other experiences. This was from a family caregiver, a different way to survive. So we really were able to learn from them. So I'm going to stop here. And I've got 4 questions that I want us to spend, I guess, the next 25 minutes discussing. And it's, and I think you've probably been talking about this before, but research in your area that's important to you as a group and that needs to be studied. And then if we can just, it may come up in the research questions, but what are the outcomes that matter to you as a group and to your population? And then let's talk a little bit about methodology and how we might go about studying this topic. And then let's talk about the study participants. So the research questions, the outcomes that are important, ideas about how to study the topic, and then who would you include in the study and how would you recruit them? So I think you've probably talked a lot about the questions, I think, over the last year and a half. And so I think if we start there, and I'll turn it over to the group. If we find we have lots of people talking, then maybe I'll get you to raise your hand. But I think, why don't we just start talking about some of the questions that are important to you in your substantive area?
Well, we've been talking about mental health and CHD. And so that's one of the things we're very interested in, one of the topics that we've been interested in looking into.
And so when you talk about mental health, is it documenting sort of different mental health conditions that people may have with CHD, or is it around an intervention for it, or what have you talked about in terms of mental health?
I think we've kind of talked about both, actually.
Yes.
Both aspects of it.
One of the big concerns is how do we treat it, because most of it causes heart palpitations and rapidness of heart and things like that, which we already have. So we don't want to add on to that.
Yeah.
So it's a combination. How do you balance both things?
Mm-hmm.
Because they're both very important and they both need medicines. But what if one contradicts with the other one? Mm-hmm. So there's the difficult thing with this.
And excuse my my lack of knowledge of this area, but is there is mental health something related to the condition that people are experiencing that's different than the general population?
In my opinion, I think one, it could be related, but at the same time, all of our hospital stays, everything the trauma that we go through can be escalated per person and individually. So that's one of the things that we look at, because we handle things differently, but our treatment has to be different as well.
And I think it doesn't always show up until maybe later in life, maybe not right away. as a child. Some people, I mean, it's different for different people when they start stressing or having mental issues about their condition, their health.
Just the fact that some of us might feel like, well, I have this so serious heart condition, most probably I'm going to die soon. And just having that thought in your mind and just trying to go on with life and surviving physically with a heart condition and your mindset that's confusing, that's when I think, like somebody said, it could take time till you really know that it had been affecting you all the time.
Yes, and another thing was that, like, I guess leading up to that was like, for some of us who, I'm from El Paso, like a border town. So not really having the ability to have a lot of intervention for me in regards to mentally, like how I'm dealing with things or anything like that. What really made a difference was when I did go to a bigger city and I was given information on even a pamphlet of, well, if you struggle with mental, you know, if you need to speak with someone or if you need anything like this in regards to it, to me, it was not known. We didn't talk about that. I was never given that opportunity. So I think that's another thing that we're all looking at is the opportunity to maybe do something about that before it gets to that point, because we've never been told. Or, okay, yeah, if you're not feeling right, if something's not right, it's okay. You can talk to somebody. Here's your outlets. Here's your ability to talk to someone. This is what we can do for you. Didn't have that here. Not until I went to a big city.
I also am from El Paso, and I feel you on that one, because it was, oh, you'll be okay. Oh, it's just like, oh, it's not that serious. And I moved to Austin, and now everybody's like, okay, how can we help you? What can we do? What do you need?
I'd also like to add, I'm from Brownsville, also a border area, and that was one of my concerns mentally. I didn't know who to talk to, where to go, until I wound up in Houston. And then I felt my stress level went way down, but I was very concerned that I was not going to make it and stuff like that. So it's very important that we have access to information to calm us down.
I think that in general, like when you're younger and you're, going through all that, it's like the doctors are just, trying to save your life at that point. It's not really about anything else. Like forget mental health and all that. We're just trying to keep you alive. And then after that, once you're an adult, in my experience, like I've always been fixed. And it's like, that's all in the past. You don't need to talk about it anymore. That's kind of how it was treated. And in one way, I'm grateful for that. But in another way, I'm also like, kind of grew up not knowing anything about my heart until I was 18. And then if I had any, I didn't meet a single CHD person. I didn't even know what CHD stood for, honestly. I didn't know anything. And then if I felt something off, I kind of have a fear of needles, and I didn't know where that came from. And my arms, right here, are completely numb. I can't feel anything because of the amount of IV needles I've had. And I thought that was just me being I just thought everyone had that, So there's just a lot of stuff that kind of went without an explanation that I kind of just shoved away because I was fixed. So I think in the adult population or young adult population, teenagers, everything after all the initial surgeries and everything and all that. I think my last one was when I was 5. I had the Pontan surgery, 3-step thing. But after that, after recovery and all that, it was just kind of not talked about, and no resources were handed to me or my parents. No one said that you're more susceptible to all these things. And I think we need to be careful about that, because I don't want to say, okay, because of this, your child is more susceptible. And then they have they're afraid of it. And then they start thinking about it. And because they're thinking about it, they, get the illness. So there should be a balance between the two, but also they shouldn't be completely clueless either. And if they were feeling off, there's validation for it, and they should know that there's a reason for these things. So I think, I don't know, that's just my experience.
Yeah. I agree with that, because as a CHD patient, we feel things like heart palpitations or we feel weird, and we're always told, oh, it's anxiety. Oh, it's just anxiety. But I'm like, what if it's not? It could not be that, so everything is always pushed off so fast as an anxiety symptom because a lot of the things that we feel match up so closely with that, but it's not always anxiety. Sometimes there is something wrong.
My daughter was born 40 years ago, and I don't think mental health was ever anything that was discussed and we went to Texas Children's. We were in a big hospital. We live near Brownsville on the border in Harlingen. So yeah, there weren't a lot of resources and it wasn't really talked about mental health. I don't think I ever really thought about that as so much, but I know just the other day she mentioned to me she wants a 40th birthday party, a big party. She says, we didn't think I'd live this long. So I know that it's in the back of her mind. She's a Fontan also, single ventricle. So yeah, I think it's something that, and she has an extreme needle phobia, which I did try to get some help for when she was a teenager. But I think it was too late by then. That phobia is in her mind. She knows it's a phobia. She knows it's not, it doesn't hurt like, that bad, but she just freaks, totally freaks. And I think and I keep telling her she still needs to go and talk to somebody, but I can't make her. So.
I think part of the problem is that we want to go and we want to get that help because we all have the phobias. I hear the word needle and I scream and they have to hold me down. So I know what your daughter feels like. I know what she's going through.
Yep.
But not all these doctors understand that.
Nope.
I think we need to hope one day that there'll be a assistance for people with disabilities or special circumstances such as us, because I can go to a physician and say, well, I'm not feeling good, this, and this. Oh, you're just going through this, but they don't know our track records, our history, why this developed. Right. Because I have that fear of needles. I have a fear of people in costume because when I was in the hospital, at children's hospitals, they have clowns go visit you. They have this visit you and fun things. But in your mind, oh no, this has to relate to my heart issue. When I see a clown, it's because it's associated with surgery. So I have to know what's behind that. So we all develop different phobias. We all develop different fears that the regular doctor doesn't understand. So we can go to a regular doctor and say, oh, this, and they're going to diagnose us like if we're just somebody off the street coming to talk to them without knowing what our background is.
So I'm going to stop you here for a moment just so we can, this is amazing conversation. You really have identified what looks to me like an important gap in care, and that we don't really, it hasn't really been addressed with people with CHD. I don't know the literature, but the fact that all of you are sitting here saying we have anxiety and other issues, probably stemming as I think, Leticia, you talked about the fact that people are so concerned with saving your life that those other parts don't get addressed, and also dealing with things that probably happened to you through your life-saving surgeries when you were younger. So what I'm hearing, and just jump in if I'm not hearing it correctly, but I'm hearing that particularly anxiety. I didn't hear people talking about depression as much, but I certainly heard anxiety. And I think when I think of what you've all been through, it doesn't seem unusual, but is that anxiety even being identified or being addressed within the healthcare system? Some of you talked about, I think being seen. I think when I was here before, we talked about specialized centers for adults related to CHD, but is it being addressed in other places where you might be seen, or is it just being brushed off? So I think that you have really identified an important research, an issue, a topic. If you were trying to make that into a question, and in terms of mental health? Is there a way that you would think about how you might make it into a question? Whether it's kind of understanding it more and what people are facing, or whether it's thinking about, is there a way that we might intervene? And you talked about medications, and that kind of medications may cause palpitations and the difference. Are there other interventions that you think, rather than medications, that might be helpful to think about in terms of addressing it? So I've asked a whole bunch of things at once, but I'm thinking about, first of all, the question, and then once you have a question, then that's really what drives how you might be studying it.
I think question is, how do we address the mental health issues and the social stigma that comes along with it? I think that's mainly the question.
So is it how does are you thinking about the healthcare system and an intervention that they might address that might lead to less anxiety in people with CHD?
Correct. Yes.
And so are there other outcomes that are important? Anxiety, obviously something related to anxiety. Are there other things that might be related to an intervention for anxiety that would be important for you? And I'm not want to put words in your mouth, but I'm thinking, are there things that anxiety prevents you from doing, or other things you might want to measure as outcomes related to?
Correct. Yeah, quality of life, for example, like you may not be able to do certain things, and that may cause some sort of discomfort to you.
Mm-hmm.
And so quality of life is one that I would definitely associate with this.
I think maybe too that the anxiety keeps you from seeking help for let's say you need to go get a flu shot and you don't do it because of the anxiety of the needle. That kind of
I was going to say maybe phobias almost.
Phobias, right.
That's really interesting. And are you talking about the phobias related to everything you've been through, particularly as a child up to this point?
Yes, because I had a similar experience to what some other people are saying. I was diagnosed with a heart murmur as a child, and I was having every 6 months, tons of tests, just basically the same story, for the sake of not repeating it. And then my parents literally were like, we're not putting our kid through this anymore. You're not doing anything, which can debate that decision another time. But I was utterly terrified of doctors, and I never knew why until I was kind of re-diagnosed later in life and read some stuff about, there's some small, minor studies of PTSD and crazy fears of needles and stuff, and in children who have gone through these kind of things and CHD patients. And I just thought, oh, well, that makes a lot of sense. So, I almost didn't go to college because I had to get a vaccination. It was that level. It was utterly ridiculous. It made no sense. There was no logic, none.
I would also add that in my case, I'm also single ventricle. I've had a Fontan and a revised Fontan. And the thing is that I got my first surgery when I was 24. So I would also add to this that I'm from Mexico, so there was no hope for me. And I was alive because of a miracle until there was something for me when I was more than 20. So I can also relate to a lot of anger when I was small, because you cannot do this, you cannot do that, forget about getting married, forget about having sex, forget about having children. You're not going to do any of that. And I just shocked myself. Thank God my parents didn't really understand a lot of English. So some of that information I kept to myself. But there was a lot of anger because doctors were telling me things that they didn't even know if I wanted or not. It was like, it's not an option. You cannot do this if you want to survive. So I think that handling all of this, not only fear, anxiety, anger, a lot of things, when there's not a lot of information, you feel very lonely. It's a lonely path. So all of this has to affect somehow.
But there is still, I know how you said that depression wasn't one of them, but depression is in there because, like, on my aspect, being told several times by different cardiologists, you may not make it to, hey, if you make it to 30, great. And then it's the fear of, okay, I made it to 30. What now? Like, I was scared up to that point. Am I going to make it? And then it's trying to almost do things quickly, because what if you don't make it? And again, there's no one to talk to because the doctors are not helping you in that aspect of, it's okay, it's all right, don't worry, it's just in case we need to do something at that point. But that's not what you're being told.
So just again, to summarize what I think I'm hearing, and Chris had mentioned just putting some notes in the chat as well. And I just want to just read what's in the chat, because I think it really broadens the discussion that we started about talking about scars and body image issues, insecurities. Let me just go down here. And then talking about phobias, anxiety, anger. So initially we started up here, mental health issues, and then we started talking about anxiety and the fact that some of the medications one may use for anxiety are causing more palpitations and more problems. But now we've broadened it a lot more: depression, anxiety, phobias, anger. So so I think, to go back to Dipendra and your question about the research question about how to really understand and deal with these broader issues, I think with someone who has experienced everything that you've experienced in your childhood and later on with surgeries, it now becomes a different question, I think. And you have a lot of outcomes that you've looked at: reducing anger, reducing anxiety, the stigma, body image, all of those things. So if you were going to think about intervening, and this really is a quick run through the top of the ideas, but I think we've centered into some of these emotional issues, mental health issues that aren't addressed because the physiological issues seem to take precedent. And now we've talked about a lot of them. What do you think are some of the things that might be interesting, that aren't out there, that might be interesting to explore?
I think
different kinds of interventions. Sorry, Jessica.
Sorry, I think this is very helpful because we know we're not the only ones going through it. There's other people that we can talk to and get ideas and help. And hey, I did this to overcome this. The social groups to help each other.
Yes, I agree.
So it's a little bit like in that intervention, the Brown article, where their chronic kidney disease people talked about peer support. And I think, helping them to understand the pathway.
Yeah, because we think we're alone. We think we're the only ones going through it. And me being part of this group, it's like, oh, wait, you have a scar exactly like mine. What did you go through? And we're hearing everybody say almost the exact same thing. And it's good to hear. It's good to know you're not alone.
That helps you.
Absolutely.
So peer support. What about information? Somebody mentioned they've finally got a pamphlet. When you go even to a tertiary care center or a specialist center, or I don't know, are usually followed by your family doctor, and you go, I think, annually to a tertiary center. Is that information there about these other parts of things that you're experiencing besides the physiological things?
No, because this is where general. I'm sorry, Jenny. That's just general information.
But even with that, it's the fact that, like I was saying, I would love for there to have been something even just at the first level, just the cardiologist, or maybe in the emergency care, or maybe in a different, like you were saying, a different area, before I had to get to a bigger city to get that information. Because I think if we would have had it here, I would not have been scared. I would not have been anything before I had to go to a bigger city. Because even going to that bigger city, I was afraid of what really is going to happen to me. But if I would have had some sort of support or some sort of aid or something to research or read about, or even have someone talk to me, even a person in that just place to talk to me, it would have been very different.
So you're kind of highlighting an intervention that has some form of peer support within it, that has information, better information, but information that isn't just within these very specialized centers, that needs to be disseminated more broadly. And that's, trying to understand how that would happen, whether it's information pamphlets that are out there that people have more available, or a package, when people go from the tertiary care center, of things that they're going to need. What else could be part of that?
I think too that when you go to have a procedure or to get an injection or whatever, that many times you can tell them you have this anxiety, but
they don't care.
They don't believe you, or they don't. And then as a parent, when I would tell them, and then when she, go ballistic, they were like, they didn't understand why. What's the matter with this? Why does she act like that? Well, because
the response that I always get because I have a needle phobia too. You've had 5 open heart surgeries. How are you afraid of tiny needles?
Mm-hmm.
I'm like, it's not really the needle that's the problem. Exactly. It's like what happens after, and it's all like, everybody's giving me so much crap because I didn't get a COVID vaccine because I've been too afraid of the needle, and then once it's in me, I can't take it out, like the medicine they put in, and if I have like a heart reaction to it, then what? It's stuck in me, right? And so everybody's like, they don't understand. Oh my gosh, it's not that big of a deal. So many people do it, and the needle is so tiny. I'm like, it's not always about that. There's like deeper reasoning behind all of this.
So really, we're talking almost about 2 interventions here, one for families, for people who are with the condition and the need for information and peer support, but the need for an understanding on the part of healthcare professionals and an intervention with them as well, which brings us to the last question in terms of the population. And I think we're getting, close on time, Chris, because I want to be respectful of your time, but let's focus on the individuals with the condition and their families, who, if you were going to design a study that said we're addressing these mental health or emotional health conditions that are part of this whole package of having had surgery and having this condition as an adult, and we're going to design this intervention that has some sort of peer support information, who do you think are the people that should people get this as they transition from, should they get it at the tertiary care center, the intervention, or who are the people that this intervention should be applied to, or should it be as they transition from pediatric to adult? Think about the population.
I think it needs to start as like the baby is diagnosed and give it to the parents, because I'll say, I think part of my issues is that my parents were so overprotective because they had no information. So they're like, oh, if she does this, she's going to die. If she doesn't take her to jocks and at 8 p.m. on the dot, she's going to die, right? And then they ended up taking me off of it because it didn't do anything. And they're like, wait, what? So I think it needs to start with the parents at birth, because I think they project a lot of our issues onto us. Like, they did it the best that they could, but they weren't educated either.
We grow up scared because they're feeding onto us their fears. So now we're fearing for it.
Of course.
Because with me, I gave birth to 2 children, and my thing was, you can't get pregnant because you're gonna die. And I said, oh yeah, watch me. And I did it anyways because she told me I couldn't.
Same for me here. Same for me.
And nothing happened.
I agree that it should start
born happy and healthy. So I mean, everybody's different.
Could it be that we need to have this, like she was saying, at birth for children? But could it be that as soon as it's at a cardiologist, just a cardiologist, not a specialized, like a congenital heart or any other, like the higher up kind of as you go, but just at the cardiologist level, when you first go in, when you're first diagnosed, when something is seen, I think that's more of what you're trying to say, right? As soon as you're diagnosed, that's when we should have like pamphlets or something on the side to be like, okay, there's also these for you to kind of review. Look at this. My parents, like you said, my parents didn't have that. So maybe having that at that level will help for that understanding before you start getting more and more into things.
Yeah.
Not only that, go ahead.
I was just going to say, I was born in 82. Back then, they didn't do ultrasounds on the mom unless there was like a prior kid with issues. And so I'm the first person in my family with CHD. They had no idea I had it till I came out and I was blue. And the nurse was like, wait, why did you just have a blueberry? So they basically had no clue. But now things are a lot different. And I think that you can be diagnosed with CHD before birth. So I think that like giving parents who are expecting a child with CHD would be a lot better now because they'll be prepared before the baby's born rather than, oh crap, we don't really know how to deal with this. Yeah.
Yeah. My daughter was a month old before she was born in 83. And of course there were no ultrasounds or anything. And there were no support groups and there was no Facebook or anything at that time. So, but we had very good doctors and they were very good about educating me. But at that time, Fontaine was not done that like it is today. And so, yeah, I was scared. I mean, of course. So, yeah, I'm sure that projected to my daughter too.
I just think quickly, I think the big thing we're saying here is the earlier, the better. It's basically what we're saying.
Yeah.
And I can just say my husband, he's a nurse and he works at our local children's hospital and he works in surgery. So he sees all the parents come in for children that are having their heart surgery and the anxiety that they are going through. And he says the moment he loves getting those patients because he tells them about me and he connects with them that way. And he tells them how old I am and all the things I've done. And the anxiety just like drops, like the hope they get going forward that their child could be normal and have a normal life. That's what they need to hear. And
our stories, from what I noticed, our stories help out a lot of these new patients. Because when I had my last surgery, I was 19 years old. And the little baby next to me, because I had it at a children's hospital, my mom was with her the entire week I was in the hospital because my mom was kind of helping her out, getting through what she was going through. Because I was 19 years old, her baby was 1.
Wow. This is an amazing discussion. I think, just to recap, and then I'll turn it over to Chris, we've really gone from, what's a gap in care, mental health, emotional health, what are some of the outcomes that are important, how might we address this with an intervention, and then who's the population. And actually, I was thinking it was all of you, but it's actually, as you said, going back further to even think about how do we help the parents who can then not maybe pass some of those phobias or anxieties on. Thank you so much for the opportunity for me to learn more from you about CHD, but also for being so interactive with your own experiences and your expertise.
Nothing at this time. Thank you, Carol. Thank you, everyone, for showing up.
Thank you all.
Thank you.
Have a great night.
Thank you.
Bye. Good night.
Bye.
Thank you, Chris.
Thank
Good
you.
night.
Good night.
Thank you.